Hey everybody, this is Shannon Finks with the Finks 5, and the Finks 5 is where we review a therapeutic topic within 5 to 15 minutes. Sometimes we have 5 points. And today is specifically geared towards my students on the subject of when you should use a statin and why you should use a statin in someone who is at increased cardiometabolic or cardiovascular risk. The first point is that we should use evidence-based guidelines to initiate a statin in certain groups of people. This data comes from the cholesterol guidelines, which was updated in 2018 specifically for statins. And the evidence is based upon the underlying risk for atherosclerotic cardiovascular disease and the anticipated benefit from the drug. So this is not based on someone's LDL value alone, but based upon evidence that was supported from clinical trials demonstrating that statins provide enormous cardiovascular benefit, especially in 4 groups of people. So this guideline is going to suggest 4 groups that benefit from statin therapy. And we should determine the statin intensity or that dose based upon that individual's underlying cardiovascular risk. And the current guidelines, not the 2018 or 2019 guidelines, they used a pooled cohort equation, but currently in 2024, we're using a prevent score, which is a calculation that has slightly been altered from the pooled cohort equations that was published in this updated cholesterol guideline. Point number 2, the reason why we use statins is because they reduce major adverse cardiac events. MACE reduction occurs about for every millimole of cholesterol that you can decrease, and depending upon your lab, that might be around 40 milligrams per deciliter decrease in LDL. You get a 22% reduction in major adverse cardiac event like death or heart attack. And this is comparable both in someone who has never had a heart attack before or a stroke before, the primary prevention population, and the secondary prevention. So someone who has already had an event, they're very high risk for having a subsequent event. And statins work in both populations. So when we look at the absolute risk reduction, though, it's about 5% in secondary prevention trials and about 1.5% in primary prevention trials. So this is very significant, and we are using statins to reduce major adverse cardiac events in both primary and secondary prevention. Point number 3 of when and why to use a statin. The guidelines based on clinical evidence is going to outline 4 groups of people that are expected to derive the most benefit from statin therapy. And the first group are those people who have clinical atherosclerotic cardiovascular disease. This is established disease. This is someone who has had an MI, a myocardial infarction, or a heart attack in the past. This is someone who's had a stroke in the past. This is someone who has had a CABG or some type of surgery to bypass atherosclerotic lesions in the heart. And this group of people is the priority for statins. They will derive the most benefit from statin therapy. And this is your secondary prevention population. And these patients will need a high intensity statin. Group number 2, or statin benefiting group 2, are those patients with really high LDL cholesterol, and the guideline sets this high threshold at 190. Sometimes you may find that this is a genetic predisposition, but anyone who has an LDL that's greater than 190 is at a really high risk of some type of heart or stroke event, and we're going to treat them with statin therapy because the evidence overwhelmingly suggests a reduction in major adverse cardiac events in this particular population. Statin benefiting group number 3 are patients with diabetes, and this could be type 1 or type 2. Generally, this falls into the age range of 40 to 75 with an LDL that's greater than 70. And so this is for all diabetic patients, and this is the third most highest priority. And typically, we will start with a moderate intensity statin in this group of patients. The last statin benefiting group, or statin benefiting group 4, is the general population, generally aged 40 to 75, and they have an LDL that's higher than age 70. But in this group, this is your primary prevention group that has not had any heart event or stroke. They don't have diabetes. They don't have really high LDL cholesterol. And so we're going to base whether or not to begin a statin in these individuals based on a shared decision, but it starts with an underlying risk assessment. We're going to calculate a prevent score and estimate their atherosclerotic cardiovascular risk, and then determine whether or not they may derive benefit from a statin. So this table summarizes the 4 groups that benefit from statins, but it also outlines the intensity of the statin that's chosen. So if you start at the top with statin benefiting group 1, these are your highest risk patients. It makes sense that we're going to use a high intensity statin in them, unless if they're elderly, maybe age greater than 75, and we might back down the dose a little bit because elderly patients are more prone towards statin adverse events. But for the most part, we're going to treat these guys pretty aggressively to reduce their risk of subsequent event. Then statin benefiting groups 2 through 4 step down in intensity. Statin benefiting group 2 is pretty high risk, and we're going to use a high intensity statin in them. And in the diabetes population, we may start with moderate intensity statin, but we may increase the dose based upon their risk factors or their age or their family history or other risks that may not be that may not be included right off the bat in a ASCVD risk calculator. And then for the statin benefiting group 4, the general population, we will start with a moderate intensity statin, generally if that person has an ASCVD risk that's greater than 7.5%. But we may be more aggressive or less aggressive depending upon other risk enhancing factors. You will want to memorize your high intensity statins. These are atorvastatin 40 to 80 or rosuvastatin 20 to 40. These dosages of these 2 statins will be expected to give you greater than a 50% lowering of the LDL from baseline. Moderate intensity statins are outlined here, and we very rarely use low intensity statins. The reason that you might see a low intensity statin is in a patient who might be sensitive and have adverse events associated with their therapy, or we may see a drug interaction where we limit the dose or we may cap the dose of that statin, because with the drug interaction they're actually getting a higher dose of that statin than is assumed by the current dosage. The majority of our patients that we see are in statin benefiting group 4, or this primary prevention group. And this is the guideline from the ACC-AHA, and this is something that's extremely important. We take that patient's underlying risk, their prevent score, and we look at, are they low risk, borderline risk, intermediate risk, or high risk? And in general, at that prevent score, or that ASCVD risk calculation that is higher than 7.5, we start to have a risk discussion with that patient, and that starts to favor statin therapy when their underlying risk is greater than 7.5%. Those patients who have borderline risk that fall into that 5% to just shy of 7.5%, we may go ahead and talk about statin therapy in this particular population, though, because The ASCVD risk calculation may not include other risk enhancers. So, for example, a family history of an early atherosclerotic event or some other type of inflammatory disease that may not be that may actually increase that person's risk for a heart event. And I use this as just my starting point when I start to have a discussion with patients. I try to understand that what they value, if they have a family history, what they want to avoid, how aggressive do they want to be. And in some cases, I use a calcium score to help us make our decision on whether or not a statin would benefit them. The CAC score, or the coronary artery calcium score, can help in decision making. Basically, if you have calcium that's detected on this scan, calcium does not belong in the smooth muscle tissue of the vessel wall, and that means that plaque has calcified. And so anything other than 0 would potentially steer me into the direction of giving a statin in that patient. The guidelines, number 5, point 5, the guidelines on when and how to use a statin always requires a patient-centered approach, and the guidelines discuss shared decision making. So we're going to use the risk factors that are unique to that patient. We're going to talk about the benefits of therapy. We may discuss the potential risks for adverse drug interactions. We're going to look for drug-drug interactions. We'll talk about the cost of therapy. We're going to look at other risk-enhancing factors in that particular patient that may favor statin therapy. We may use a coronary artery calcium score. We're going to go with patient preference, and we want to set that patient up for success. We want them to be adherent to this therapy, because ultimately this adherence to therapy is what drives the major adverse cardiac risk reduction. If you don't take a statin, you're not going to derive the benefit that may come from that statin. So in summary, 5 points. When and how to use a statin. First point, the decision should really be based on evidence-based guidelines. Number 2, statins are used first and foremost because of the robust data showing the reductions in major adverse cardiac events. Point 3, evidence-based guidelines suggest 4 groups of patients that are expected to derive the most from a statin, and they are outlined in order of priority. Who is at the highest risk? Statin benefiting group 1, all the way down to the general population in statin benefiting group 4. You may use objective data or risk enhancing factors like a coronary artery calcium score to aid in the decision to start a statin therapy, but always, this should be a patient-centered approach, and starting a statin requires a shared decision when you go through risks and benefits. We'll have another Finks 5 on statin alternatives, and we appreciate your attention today.